I will now start with my talk, which will be about 15 minutes. And the topic is going to be on limb salvage or prevention of lower limb amputations due to diabetes in a developing country, which is India, and particularly in my city called Chennai in India. I would like to start with this slide where we compared the amputation and risk factors for diabetic foot in Germany, Africa, and India. So there are three continents across the world, and this was published in 2003 in the diabetic medicine, as you can see here. Now, what we found here was we had about 600 patients from Germany, from Africa, and India, and we found that the major cause for amputation in the developing countries like India, Africa, and so on was progressive infection. The prevalence of peripheral artery disease was lower than in Germany, but the amputation rates were higher because of neuropathy and because of progressive infection, which seems to be the primary reason for amputation for people in the developing world. Even among India, when we did a study among 1,300 patients from 31 centers from India, we again found that it was infection which was the major cause for amputation in our country. So these were the 31 centers from India where the study was conducted, and you can see that 90% of the amputations which occur in this developing country, India, was due to infection on top of diabetic neuropathy. Now, there are some patients who present with purely a neuropathic wound, but there are patients like these who present with a neuroischemic lesion. And particularly, you can see the gangrene of the heel, which is the one of the most difficult areas in the foot to treat. Now, this patient definitely has no blood supply. It's a neuroischemic wound. So what we do is first we do an angioplasty and then do a good debridement. Without angioplasty, without revascularization, without establishing the blood supply to this part, it won't be possible to do limb salvage. So you can see after angioplasty with wound debridement, the wound started granulating. Then we put the vacuum assisted closure, VAC therapy, and finally we do a skin graft. So you can save many limbs in the developing world where peripheral arterial disease is less, but it does occur by getting the help of a vascular surgeon. So every wound should be examined properly and you should get the vascularity assessed properly with an ankle breaking index or with a color Doppler or with an angiogram, what we call as DSA. This is our DSA machine where you can see the blood supply is not very good in this person. You can see that there's only one artery, the anterior tibial artery, which is seen, the posterior tibial artery is not seen. So you have to revascularize such patients. This is a beautiful algorithm from the King's College in London by Professor Mike Edmonds and also by Ali Foster some years ago, but still very much valid. And this is a stage, the stage one and stage two, when you have a normal foot and a high risk foot, that we as physicians and primary care physicians must identify these two stages and prevent patients from getting into an ulcer stage, infection stage, necrotic or gangrene stage, and so on. So let me spend 2 minutes on how to examine a person with diabetes for high risk feet. Now, there are many methods. The best method is to use a 128 hertz tuning fork and also temperature, test the temperature, and also look at the ankle reflex by using a tendon hammer. You don't need any expensive gadgets to make a diagnosis of a high risk feet. And then you can feel the pulsation of the posterior tibial pulse, the dorsalis pedis pulse. If you have an ankle brachial index, you can use it. We documented and validated some years ago a 128 hertz graduated tuning fork, which I will show you the photograph, is a very simple device uh, which consists of gradations here from 0 to 8, and it's quite quantifiable, and you can quantify the vibration perception threshold, or VPT as we call it. If you don't have this 128 hertz graduated tuning fork, you can use a simple 128 hertz tuning fork. Use a tendon hammer to look at the ankle reflex, and also you can test the temperature by heat and cold testing. There is a simple device called a tip therm, which can be used to test the temperature in an air-conditioned room, where the patient will be able to tell you the difference between a metallic end and a wooden end to test the temperature. The next important aspect after testing the high risk feet and identification of high risk feet is to have proper footwear and education. Now, this is a typical footwear which is worn in India, which is very cheap. It costs only about $2. But you see what is the damage it can cause in an insensate feet where there is no sensation. And then there are people who have deformities like these, who should not be wearing such footwear. They need customized footwear. So, in the next 2 minutes, I'm going to tell you on how we have developed footwear in Chennai, in India. In 1991, of that's 30 years ago, we involved the local cobblers who are shoe making people, footwear, sandals making people from Chennai. We brought them into the hospital and we experimented with various materials. This is a material which is called the EVA foam and the PU foam on top as the insole, and the outer sole is made of EVA. And today we have expanded 30 years later into a full-fledged footwear manufacturing unit. The footwear is, as you saw in the picture, is one of the most important aspects in the development of a foot ulcer in somebody with neuropathy. And these are some of the sandals which we have developed, which costs about $4 to $5. And they're comfortable, they're quite good looking, and it's acceptable in people who have neuropathy, who have not yet ulcerated or do not have any deformity. These are all footwear made in our hospital. What about patients who have an active foot ulceration? So we have the shoemakers who make footwear offloading methods to suit people who already have an active foot ulcer. If you have a foot ulcer like this on the first metatarsal head or on the midfoot like this, you have to give them offloading footwear, otherwise, it will not heal. And there are people who have amputation and deformity, and these people also need specialized footwear. And there are people with sharper foot who also need customized footwear. They can't wear the footwear which I showed you earlier. Therefore, a simple method is what we have learned from leprosy or Hansen's disease. We make a mold of the foot and take a cast of the foot like this and make footwear out of these casts. We also have developed our own crow, Shaco restrained orthotic walker, which costs about 10 to 20 US dollars. And these will be used in people who have sharper foot, like the picture you saw. So you have to develop your own footwear to reduce the cost, because the cost of the footwear which is imported from the United States or from Europe is very expensive. We did a small study which we published in Diabetes Care, which is the official journal of the American Diabetic Association, some years ago, and we found out that these therapeutic footwear will lower the foot pressure and also reduce the amputation rates. You can see in this study in 2004, we followed up 241 people with high risk feet in a prospective study, and we found those who wore the preventive footwear which we made versus the own footwear group. You can see that lower foot pressures were seen in the people who wore our footwear. And in the re-ulceration rate was 4% among the people who wore our footwear versus 33% in people who wore their own footwear. So I think footwear is an essential component of the treatment of diabetic neuropathy. I was fortunate enough to join Sikobas, David Armstrong, Catherine, Gustav Jal, and Carlo Caravigli and Peter Lazzarini in the 2019 IWGDF guideline for offloading. And I'm also serving on the same committee for the 2023 guideline. So I think offloading footwear is a very important aspect. And in the last 2 minutes, let me talk to you about education. I talked to you about the Train the Foot Trainer program of DFoot. This was a program which we started in India, probably for the first time in the world, called Step by Step in 2004. From India, it went to Africa and other countries. So what we did was we trained a doctor and a nurse to examine the feet, make an identification of the high risk feet, remove a callus, and also provide uh, footwear advice. You can see that these delegates, the doctor and the nurse, were taught how to remove a callus. And what happened was the step by step after 1 year in 2005 and in 2006, we found that about 15,000 patients had been examined after step by step program. For high risk feet, they were examined. And a lot of patients with trivial foot lesions like calluses were treated, about 4,500 people, and about 350 people were referred to tertiary care centers. So this is a program which is called a step by step, which was started by us in India, and then went on to Africa, Tanzania, and then it went to all other countries. So the Train the Foot Trainer program is based on the step by step. We have to educate people on foot care and prevention of amputation. Therefore, I would like to conclude my talk with the five cornerstones of prevention of diabetic foot, especially in developing countries like your country, in Latin America, in Southeast Asia, and in Africa. The first method is the regular inspection and examination of the at-risk feet. We have to identify people who have neuropathy. Having identified the at-risk feet, we have to educate the family, educate the patient, educate the healthcare providers by the step-by-step or train the foot trainer program and so on. It's very important to give them the appropriate footwear, otherwise they will ulcerate again. And then treatment of non-ulcerative pathology would mean removing a callus and treating a callus so that it will not become an ulcer. And this was a study which we published in 2005 that if you give proper foot care education, you can prevent an amputation. This was published also in the Journal of the American Diabetes Association. Therefore, my final slide is I think preventive foot care is very, very important. We have to teach the patients about foot care, how to apply a moisturizing cream and keep it not dry but prevent fissuring. We have to teach the patients how to cut the nails properly. So all these preventive foot care steps go a long way in preventing an amputation. I would like to thank once again Dr. Emil Jubis for this invitation, and I wish the summit all success. Uh, and I would like to encourage all of you to join the DFoot in our mission to prevent lower limb amputation. Thank you for your attention.